Hi, my name is Dr. Shannon Delaney. I am a psychiatrist by training. I'm currently in private practice, but today I'm going to be presenting to you this course titled Borrelia miyamotoi Serology in a Clinical Population with Persistent Symptoms and Suspected Tick-Borne Illness as part of Invisible International's Medical Education Initiative. This program, which includes a large library of free CMEs, is generously supported by the Montecalvo Family Foundation. So like I said, I am a psychiatrist that treats both kids and adults, and I have a specialty in Lyme disease and tick-borne illness. Today, I'm going to talk to you about a manuscript that we published in 2020 while I was a faculty member at Columbia University Irving Medical Center. And the title of that paper is called Borrelia miyamotoi Serology in a Clinical Population with Persistent Symptoms and Suspected Tick-Borne Illness. I have no conflicts of interest or disclosures to report. The objectives for today's talk include Borrelia miyamotoi in the differential diagnosis of your patients who are presenting to you with suspected tick-borne illness. Secondly, we'll be talking about some appropriate testing to identify Borrelia miyamotoi infection. And then thirdly, we'll talk about how to integrate the symptoms of Borrelia miyamotoi into your medical evaluation. So you might be asking yourself, what is Borrelia miyamotoi? So Borrelia miyamotoi is a relapsing fever spirochetal bacterium, which was first identified in Japan in 1994. The name miyamotoi actually comes from Professor Miyamotoi, who first discovered this bacteria in Japan. The first human cases were reported in Russia in 2011 and in the northeastern US in 2013. So it's pretty amazing that we're still discovering new diseases. And this one was discovered, first cases in the US in the Northeast were about 12 years ago. So we know that Borrelia miyamotoi is transmitted by the same hard-bodied tick, the Ixodes species of tick, that are vectors for Borrelia burgdorferi as well. So the same tick can transmit both Borrelia miyamotoi and Borrelia burgdorferi and Borrelia miyamotoi. This is a depiction of the map of the US, and it's looking at Borrelia miyamotoi infection in ticks and also in humans from a time frame of 2013 to 2021. So in the dark blue, this represents both tick and human infection, and the light blue represents just the presence of Borrelia miyamotoi in ticks. Keep in mind, this was a meta-analysis, so this is looking at all the published studies done looking at both miyamotoi in ticks and Borrelia miyamotoi in humans. So in terms of Borrelia miyamotoi hotspots, you can see that California, especially along the West Coast, is a hotspot. The upper Midwest, especially Minnesota, and then most of the Northeast, there is a lot of Borrelia miyamotoi. So this figure comes from a review paper, which is also a meta-analysis, looking at similar things. So this is the global prevalence of Borrelia miyamotoi. So if you look on the upper left-hand side under A, this is a distribution of Borrelia miyamotoi in the Ixodes ticks. And the red represents North America, so the US and Canada. And these are the Ixodes scapularis ticks. The pink represents Ixodes pacificus ticks. So this is like California area, also Mexico and some of Central America. The blue is represented by the Ixodes ricinus ticks, and the green is both the Ixodes ricinus and the persicatus ticks. Don't quote me on that pronunciation because I've never heard of that tick before, but that is the one that is in Asia. So moving on to depiction of B, you can see distribution of human exposure to Borrelia miyamotoi. So in this picture, what they're doing is they're looking at studies that studied Borrelia miyamotoi positive serology. And you can see that most of the studies have come out of North America, and a few have come out of Europe, and even less have come out of Asia. So this will be similar to the study that I'm talking to you about today. These are serological studies looking at the presence of Borrelia miyamotoi in humans. Moving on to C, you can see the distribution of human infections with Borrelia miyamotoi. So this is looking at molecular assays such as PCR testing in human beings. So there's not many of those studies published in the US or North America or Europe, but you can see that there's quite a few published in Asia. Moving on to D, this is the distribution of human cases of Borrelia miyamotoi disease. So these are case reports that have been published in the literature about human beings who are presenting with Borrelia miyamotoi infection. And this is typically an individual case report or a case series about these patients. So you can see there's quite a few published from the US, and there's the most published in Asia. You might be asking yourself, what are the symptoms of Borrelia miyamotoi? Well, one of the most important things to remember is Borrelia miyamotoi infection is clinically very similar to Lyme disease, presents almost identically with manifestations of fever, fatigue, headache, myalgia, chills, and nausea. Similar to Lyme disease, Borrelia miyamotoi infection can also lead to significant neurological complications. However, unlike Lyme disease, we know that Borrelia miyamotoi typically does not present with an erythema migrans rash, and arthralgias or joint pains are uncommon in Borrelia miyamotoi disease. We know that patients with acute Borrelia miyamotoi infection often present with more severe symptoms, especially headaches and fever, than patients who have acute Lyme disease. In terms of the case reports in the literature, meningoencephalitis can also occur in immunocompromised patients. This has been reported in the literature. And Borrelia miyamotoi is part of the Tick-Borne relapsing fever family of Borrelias. So there's kind of two different Borrelias, the Lyme disease Borrelia and the Tick-Borne relapsing fever Borrelia. And Borrelia miyamotoi is part of that relapsing fever family. However, clinically, we typically just see relapsing fevers in a subset of patients who have Borrelia miyamotoi disease. In the literature, it's ranging anywhere from 11 to 35%. So it's a bit of a misnomer in terms of relapsing fever. Most of the patients who have Borrelia miyamotoi don't clinically present that way. We think that like Lyme disease, Borrelia miyamotoi is typically treated with 2 to 4 weeks of antimicrobial therapy, most often doxycycline or amoxicillin. I will tell you that in my clinical experience with patients with Borrelia miyamotoi, oftentimes ones who present with severe neuropsychiatric symptoms, they often need IV ceftriaxone to get better. So our study design included 82 patients consecutively tested for Borrelia miyamotoi and Borrelia burgdorferi antibodies. This was part of a clinical workup for tick-borne illness completed at Columbia University Irving Medical Center from June of 2017 until October of 2018. Our chart review was approved by the New York State Psychiatric Institute, IRB. And these were patients who were presenting to us, seeking a second opinion. We had a consultation clinic, and they wanted a second opinion about whether or not their persistent polymorphic symptoms could be attributable to a tick-borne infection or not. So this population typically was quite sick, and they frequently would endorse chronic symptoms of pain, fatigue, neurocognitive problems, and also psychiatric problems. These evaluations consisted of comprehensive physician assessments. We spent many hours with most of these patients. We did very comprehensive serological testing on them as well, not only looking for Borrelia miyamotoi antibodies and Borrelia burgdorferi antibodies, but lots of other things that you can get in a tick as well. And these patients generously completed a lot of questionnaires for us. In terms of the testing, we used a GLPQ assay, which was considered an indirect EIA for the detection of antibodies to Borrelia miyamotoi. This test was done at Imugen in Massachusetts. That was a tick-borne illness specialty lab that actually no longer exists. Quest Diagnostic acquired that company. So the good news is that you can get this Borrelia miyamotoi antibody test at Quest now. So for this particular testing, they use the GLPQ gene sequence. And this gene is unique to Borrelia miyamotoi. And we also, like I said before, we did testing for multiple different tick-borne illnesses for these patients. We looked for Borrelia burgdorferi antibodies by using both the C6 peptide ELISA and also the IgM and IgG Western blot. So we had primarily two different groups of patients. We had those who were considered positive for Borrelia miyamotoi, and this is based on their IgM or IgG GLPQ seroreactivity. So this means if their quantitative antibody was greater than 1 and it was considered positive, they went into the Borrelia miyamotoi positive group. The second group were those who were considered Lyme disease positive. These were patients who met the 2017 CDC surveillance criteria for either definite or probable Lyme disease. So this means that they either had an EM skin rash at the time of their diagnosis, or they had multi-system clinical symptoms, and they also had lab work that was suggestive of Lyme disease. In this case, at least 5 positive IgG bands on their Western blot. So like I said, we asked these patients to complete a lot of questionnaires, and they rated their overall symptoms on what was called the General Symptom Questionnaire 30. So this is a specific measure. It's 30 questions that was developed to assess multi-system symptom burden in patients with both early Lyme disease and also chronic Lyme disease or post-treatment Lyme disease syndrome. We also asked them to complete the VEC depression inventory, the cognitive failures questionnaire, fatigue severity scale, Epworth sleepiness scale, the pain scale, and the Zung anxiety scale. And then we did statistical analysis looking at patients for both of these groups and how they completed all of these measures. We used Mann-Whitney U tests to compare the Borrelia miyamotoi positive group to the group positive for Borrelia burgdorferi antibodies on all of these measures. So what did we find? Well, of the 82 patients that we saw over that time period, 21 or 26% of them tested positive for Borrelia miyamotoi based on the anti-GLPQ assay. All of the patients that we evaluated were IgG positive and none were IgM positive. Of the 21 patients who were positive for Borrelia miyamotoi, 5 of them also met CDC surveillance criteria for either definite or probable Lyme disease. And of the patients, the 61 who were negative for Borrelia miyamotoi, 22 of those patients met criteria for definite or probable Lyme disease. The remaining 39 were negative for both miyamotoi and Borrelia burgdorferi antibodies. So we generally saw a lot of similarities between the Borrelia miyamotoi group and the Lyme disease group. Pretty much indistinguishable. However, we did find some differences. We saw that the Borrelia miyamotoi positive group reported statistically significant more sleepiness on the Epworth sleepiness scale and significantly more pain on the pain scale. Again, this is compared to the group who had probable or definite Lyme disease. When we looked at the GSQ-30 with all the individual scores and individual items, we found no group differences between the miyamotoi group and the Lyme disease group. However, the miyamotoi group did endorse more headaches than the Borrelia burgdorferi positive group, but this was at a trend level and did not reach statistical significance. So what did these miyamotoi patients look like? Well, their mean age was 34 years old. We had a couple of kids who had Borrelia miyamotoi infection. 8 of the 21, or 38%, had reported that they had been hospitalized at some point during their symptom onset or course of illness. Of the 8 hospitalizations, 7 of them were for medical reasons, and 1 of them was for psychiatric reasons. Of the medical, 3 were cardiac in nature, and 2 were for neurological abnormalities. Everybody, all of the 21, had received prior antibiotic treatment, and 20 of the 21 had received at least 2 weeks of either doxycycline or amoxicillin. And you might be asking yourself, well, where are these patients coming from who have Borrelia miyamotoi disease? And does it fit with that graph that we saw of the US? Well, 16 of the 21 patients that we evaluated came from the Northeast or Mid-Atlantic region. Of the remaining 5 patients, 2 lived in California, 2 lived in Florida, and 1 lived in Illinois. Of the 82 patients in the study, this is important to remember, 80 of them, so 98% of them, had never been previously tested for Borrelia miyamotoi infection before, which we were incredibly surprised about. And among the 21 patients who were positive on the GLPQ ELISA, the Borrelia miyamotoi antibodies, 18 of them were tested for the Lyme C6 peptide ELISA, and none of them were positive. The reason why this is important is because prior literature had shown that some of the Borrelia miyamotoi patients were also presenting with positive Lyme C6 ELISA, but we did not find that in our study. So this is the first clinical study to investigate the presence of Borrelia miyamotoi antibodies in a clinical population experiencing persistent symptoms and suspected tick-borne illness. We found a very high, surprising rate of Borrelia miyamotoi antibody seropositivity, 26% in our population. And again, these were patients coming to us seeking a second opinion consultation for suspected tick-borne illness. This is a novel finding. It's higher than what was previously reported in the literature, which showed seropositivity rates ranging anywhere from 3 to 21%. These were previously reported studies. So we know that unlike Borrelia burgdorferi, Borrelia miyamotoi can be transmitted via transovarial transmission. So what this means is that the infection can be transmitted directly from the adult tick to the offspring, such that the larval ticks are actually capable of transmitting infection, as well as other stages of the tick development as well. We also know that Borrelia miyamotoi transmission from tick to human occurs more quickly than Borrelia burgdorferi transmission. Miyamotoi can occur within 24 hours of tick attachment. And there's been studies looking at ticks and Borrelia miyamotoi, and they have found miyamotoi in the midgut and the salivary glands of both Ixodes scapularis and Ixodes ricinus ticks. And we think that that probably is contributing to the faster transmission rates as well. So our high seropositivity rate in this clinical sample, coupled with the high number of patients who had never been tested before, 98%, really represents a significant public health concern in our opinion. We already know that in Lyme disease, delayed diagnosis and treatment is associated with prolonged symptoms, and we may find that the same is true for Borrelia miyamotoi disease. Our study also raises the clinical and the research question of whether or not Borrelia miyamotoi infection can lead to chronic symptoms. There was another study that was published around the same time as ours in 2020. This was a study that was done in France, and they looked at a similar population of patients. These are patients with chronic symptoms and suspected tick-borne illness. The difference with this study is that they were looking at Borrelia miyamotoi PCR positivity and not seropositivity, not antibody positivity. But they found 5% of their population was positive, PCR positive for Borrelia miyamotoi. In conclusion, to decrease the risk of prolonged morbidity, patients with an acute onset of multi-system symptoms suggestive of Lyme disease and other tick-borne illnesses should also be tested for Borrelia miyamotoi. I would add I'm a child psychiatrist. I often see kids who present with new onset psychiatric problems, and I check everyone for tick-borne illness, including Borrelia miyamotoi. Here are my references, and thank you.